Welcome to a CME podcast episode from NEI, the Neuroscience Education Institute, hosted by Dr. Andrew Cutler. For complete CME information, please refer to this podcast's description page or go to nei.global/podcast.
Hello and welcome to another NEI CME podcast. And today we're talking about a topic that's very important. It's not just tardive dyskinesia, but we're going to talk about quality of life and impact of tardive dyskinesia. And joining me today is another NEI original. Dr. Les Citrome and I were on the original faculty of NEI, and we've been friends a long time, and I can think of nobody better to talk about with this subject. Dr. Citrome is very thoughtful, very productive, publishes a lot. And Les, I want to say hello and welcome.
Thank you, Andy. That's a very kind introduction. I look forward to our discussion on tardive dyskinesia, as you know, is one of my favorite topics.
Yeah, it's unfortunately something we've got to wrestle with, isn't it? Well, we're going to really focus on, again, the impact. And of course, there's many impacts of tardive dyskinesia beyond the movements. There's physical, psychological, social, occupational impacts. We're going to talk about some newer tools and measures to assess the severity and maybe monitor our treatments. And we're going to talk a little bit about treatment. But why don't we start out at the beginning? Les, can you talk a little bit about the hallmark symptoms and features of TD?
So tardive dyskinesia is a movement disorder which consists of, irregular, jerky movements of the limbs. But we most often think of TD as something to do with mouth movements, right? Movements of the jaw. Blinking, that's a kind of odd, and sticking out the tongue, that's pretty obvious. But if you look further, it can affect the entire body. I mentioned the jerky movements of the arms. They can be seen in the fingers. They can all be seen in the feet. We can also see some truncal dystonias and truncal dyskinesias, which are characteristic also of some more severe tardive dyskinesia. And the thing about TD that is so remarkable to me, Andy, is that patients are often unaware of their movements. Yes. But That's not true for other people around them. They see these movements and they treat the person with TD differently. So this is where the problem lies. It's not necessarily the patient worried about the movements themselves. It's what happens afterwards.
Yeah, what's interesting is there's not a sensory component, so they may not notice the movements per se, but they can notice the complications of the movements. For instance, if your toes are always wiggling in your shoes, you may get a blister. Or if you're constantly biting your tongue or cheek, you can get a sore in your mouth. And if your muscle is constantly spasming, you might get a sore or painful muscle. So you're right, certainly. But a lot of people are not aware, which is surprising. And like you, I was trained that it's mostly in the face. And yet it sounds like, Les, listening to you, it can affect any part of the body, any skeletal muscle, correct?
Yeah, absolutely. This is why I emphasize this, because if we just look at the face and assume that's all there is, we'll miss the entire picture of how TD can affect that individual. Certainly, grimacing will turn people off, right? Grimacing makes someone look weird, and it's like the stigmata of having some mental disorder. But actually, movements of the hands can impair one's ability to grasp a utensil or to button a button or tie a shoelace. So it has real consequences. And if you find someone with TD and they always have food on them, well, that's because they're not necessarily just messy eaters. They can't necessarily hold a fork or spoon in a way that you and I can.
Yeah, boy, that's really well said. I have seen patients who say, for instance, just looking at me, you can't tell necessarily I have a mental disorder, but when I have this, it makes me stand out. It makes me look odd or weird. So
absolutely. And the consequences of that is, boy, I don't want people staring at me or commenting about my appearance. So I'm just going to stay at home. And I've heard stories from patients that they've stopped going to the supermarket during the day because they don't want their neighbors to see them. So they'll go later at night. And, hardly anyone shops late at night, except actually those with PTSD do that too. But basically, nighttime after 10 p.m., there's hardly anyone in the supermarket, and that's when they feel more comfortable. They also don't like it when people comment about their movements because, number one, they don't realize they're doing it. Number two, they can't do anything about it.
Yeah.
So it's not like they can exercise some voluntary control over these involuntary movements. So it's quite frustrating to hear someone say, stop doing that. Stop sticking out your tongue.
Yeah.
Number one,
Yeah.
they don't realize they're sticking out their tongue. And number two, they
Right.
can't do anything about it.
So it's very embarrassing. And, I think one of the things that human beings fear the most is losing control. I should be able to control my movements, but I can't. So that's got to be scary.
Absolutely. And,
Ah.
beyond the patient, before we forget to address that, beyond the patient is the family. The family's not going to want to take their loved one to the mall anymore if everyone's going to stare at them all the time.
Yes.
So TD is not just cosmetic. It has real
Yes.
complications, consequences regarding someone's ability to socially interact and also can affect their psychological well-being. It could make their underlying psychiatric condition worse. And as you mentioned, the sores on the feet, sores in the mouth, those are physical consequences.
Yeah.
And ultimately, can they do their job? Can they have a front-facing job with the public?
Yeah.
Probably not.
Yeah. Yeah, I can imagine from what you're saying about the family that it's got to be frustrating for the family who can't help the patient either. There's nothing you can do. And of course, it's going to limit their social life. Also, if their loved one doesn't want to go out with them or so on. Well, let's shift gears and talk a little bit about assessing and diagnosing. How is it typically recognized or diagnosed in clinical practice?
Well, unfortunately, Andy, it is not. And a lot of TD flies under the radar. We just don't see it. Unfortunately, some of us spend too much time looking at our keyboard and writing our notes on the electronic health record rather than looking at the patient and seeing those movements. But you can pick it up right in the waiting room when someone is waiting to be seen. Just look. And as they come with you to the consultation room, that's when you can actually activate some movements because they're walking. And when you walk, the dyskinetic movements become more apparent. So that's a good way to start. And then you look and then you think to yourself, what kind of movement is it? And it's quite distinct from drug-induced Parkinsonism, which is another kind of movement disorder that we often see in our patients receiving antipsychotic medication. But drug-induced Parkinsonism is associated with a slowing of the gait, reduced arm swing, and any tremor there is kind of regular at 3 to 6 cycles per second. It's quite different from TD, which is jerky movements, not regular at all, and is not commonly associated with any rigidity. So you can tease those two apart.
Right.
I mention this, Andy, because number one, if we don't look, we won't see movements. And if we see movements, we have to be mindful about what kind of movement it is.
Yeah.
Because treatment, of course, will be completely different if it's drug-induced Parkinsonism compared to tardive dyskinesia. Now, when we see the movement, and we're pretty sure it's a jerky, irregular movement, we have to check off some boxes. Number one, they've been or are on a dopamine receptor blocking agent, like an antipsychotic, because that's part of the definition, and that they've been on it for a sufficient period of time. Now, if you're older, you don't need to have as much exposure to the dopamine receptor blocking agent to qualify to have a diagnosis of tardive dyskinesia.
Right.
But if you're younger, you generally do, generally 3 months. You can also see these same movements when you stop an antipsychotic or lower the dose.
I see.
If it goes away, we've dodged the bullet. We'll call it withdrawal dyskinesia. They're still at risk for developing TD in the future, but we don't call that TD because it went away. TD is an irreversible movement disorder caused by exposure to dopamine receptor blocking agents, whether they're on that agent or not. And it's distinct from drug-induced Parkinsonism in terms of its irregular, jerky characteristics. There's some other things too. You know, our listeners might not be aware that the dose of the antipsychotic that we give our patients may impact the TD. It actually helps it. If we increase the dose of the antipsychotic, we mask the dyskinesia. Now, it's a temporary solution. It comes roaring back over time, but it's what I used to do in the old days when we did not have treatments for TD and we used a lot of haloperidol.
So it sounds like what you're saying here is that distinguishing these drug-induced movement disorders is critical, and Parkinsonism, which, sometimes people call this EPS, but we're trying to be more precise. EPS is really all of the drug-induced movements, but if we say Parkinsonism, I've learned from our friends who are movement disorder specialists that that's a hypokinetic movement disorder. So most of it is less movement, stiffness. There is one hyperkinetic thing, and I think this is where people get tripped up, and that, as you mentioned, is tremor. But tremor is regular and rhythmic, and tremor is not TD. And the TD, all of the movements are hyperkinetic. They're more than usual.
Absolutely, Andy. And the tremor in drug-induced Parkinsonism may be a movement, but it's low amplitude.
Yeah.
So it's not all over the place. Very regular and small in terms of how much that movement goes in terms of those fingers. They don't go very far. With TD, they can really look a little strange there with pretty broad movements. No, drug-induced Parkinsonism is hypokinetic in terms it's associated with rigidity and slowness, as well as a low amplitude of these movements themselves. Plus the face of someone with drug-induced Parkinsonism. It has, it's like they have a mask on, whereas the face of someone with TD is expressive, inappropriately expressive, but expressive. Someone with DIP, no facial expression. They stare right ahead.
Yeah.
Now, what's tricky is, it's tricky when they have both, but we're not going to get into that today.
No.
But typically, you can tell someone has one movement disorder versus the other. And it's not going to be the end of the world if you make a mistake and institute the wrong treatment, because it'll just get worse. So reverse course, and you made a mistake, and they have that other movement disorder. The other thing I'd like to mention while I have the microphone is we can do something about drug-induced Parkinsonism that's really easy. Change the antipsychotic. That's my go-to strategy for DIP. It is not benztropine.
Okay, so you switch to a lower potency antipsychotic, in other words, one that has less affinity or less tight binding to D2. Is that what you're saying?
I would go to if they're on a first-generation antipsychotic, switch them to a second-generation.
Yeah.
If they're on a second-generation antipsychotic and they're doing well, you're kind of hesitant. You're hesitant to do anything there, and I would try lowering the dose. That often goes a long way in helping someone with DIP. But ultimately, you may want to switch off that second-generation antipsychotic for another one, because they are different in terms of their proclivity to be associated with drug-induced Parkinsonism, with some causing like very little or none.
Yeah, that's very true. Now, what about the proximity to starting an antipsychotic or increasing the dose? How does that help me differentiate?
Well, that's a good one, because when you stop or reduce a dose of an antipsychotic and movements emerge immediately and they're dyskinetic, we know it's withdrawal dyskinesia. But what you're probably getting to is when you start an antipsychotic in someone who's not been on one, and they develop a movement like within hours or days or a few weeks, it's likely not tardive dyskinesia. It's likely a drug-induced Parkinsonism, because TD takes a little while to rev up. And so you do anticipate some delay between exposure to the antipsychotic and the development to TD. Now, the odd thing about TD, which is actually quite unfortunate, is that TD can emerge even in those drugs that seem to be immune from drug-induced Parkinsonism. It's because the actual mechanism of how TD emerges is still there. Blockade of dopamine receptors. No matter how feeble that blockade is, ultimately in vulnerable individuals, they may develop TD. So that's certainly a problem. And I look forward to the day of having treatments that don't have anything to do with blockade of dopamine D2 receptors.
Well, it turns out, as you and I know, there are some drugs in development that are muscarinic acetylcholine agonists that may not. So that's in the future. But for now, as we're talking about this, is there differences in what TD, how TD behaves or what it looks like in patients with different underlying mental disorders, such as schizophrenia or a mood disorder? Are there differences there?
Not really. So we may, there is the thought that TD actually emerges more frequently amongst those with mood disorders. But I'm not so sure about that. It's kind of a weak association. The strongest risk factors for developing TD has always been, and I think always will be, how old you are and how long you've been on that antipsychotic. Secondarily, there may be, having a mood disorder is certainly not in your favor there. And having been exposed to anticholinergic agents also is a risk factor there. But basically, if you're older and you've been exposed also to more antipsychotics over your lifetime and you have a genetic vulnerability, you're going to get TD. But I like to say to people, look, if I gave an antipsychotic to a 60-year-old, their risk of developing TD is almost tenfold higher than if I gave it to an 18-year-old. So that's a definite association there in terms of risk. But that 18-year-old will catch up in no time at all if they're on a high dose of an antipsychotic for a long period of time, which we may have no choice about. Mm-hmm. Now, thankfully, the days of haloperidol high-dose long-term treatment are gone, and we use second-generation antipsychotics at doses that are much more reasonable. And I think we've managed the risk of TD much better today than we used to, but it's still around. It's been estimated that about 1 out of 14 people on second-generation antipsychotics whose lips have never touched a first-generation antipsychotic, 1 out of 14 will get TD or have TD. Yeah. So if we think for our listeners, how many patients you see each day on an antipsychotic, I think you'll reach that number of 1 out of 14
easily
on a routine basis.
It may even be higher than that, Les, because the study you're quoting was done in patients who are mostly on clozapine. So it may be as high as 10%.
Could be.
Anyway, what it is, and we're giving these drugs to so many people now. Other risk factors include the potency, how tightly it binds to the D2 receptor. And what about people who get acute drug-induced movement disorders like Parkinsonism, akathisia, or dystonia? Is that something that helps me? Is that a risk factor?
It is. It's a relatively weak risk factor, but if they're on a higher potency D2 antagonist, yes, I think so, because that'll resemble a first-generation antipsychotic. And we know those are certainly more risky than the newer agents. The idea of having a movement disorder, of let's say drug-induced Parkinsonism or akathisia even, being a risk factor is true, but it's not as high a risk as if you're 60 years old.
Age.
So I would put it in the mix. Look, if I have a patient who is 40 years old, who has a history of movement problems on antipsychotics, they're at risk, period. And I need to be mindful about the future occurrence of TD.
Yeah.
Now, I did mention being on an anticholinergic like benztropine increases one's risk. And some people assume that it's because they have drug-induced Parkinsonism. But, a large portion of patients on anticholinergics don't have DIP, drug-induced Parkinsonism. Yeah. They're on benztropine for prophylaxis. Completely unnecessary and places them at higher risk for developing TD in the future, regardless of any movement disorder they may or may not have. Yeah. So as you know, Andy, you and I both share the same belief about benztropine or other anticholinergics. I think we need to avoid them in general.
Well, you know what else? I think people are using them for things that they're not effective for. So TD we mentioned, but also akathisia. They're just not as effective for that either. So they're appropriate for Parkinsonism, but not really for long-term chronic use. As you said, there's other ways of dealing with it, lowering the dose, switching, and so on. Let's shift gears for a second. And I guess one other thing, Les, I've always wondered about. We give a lot of people these D2 blocking agents, and they don't all develop tardive dyskinesia. So obviously there must be some genetic predisposition or risk that we're just not yet able to ferret out.
I agree, Andy. There are polymorphisms of a variety of genes that confer risk for developing tardive dyskinesia. This genotyping, though, is not ready for prime time, so we can't implement these tests in the clinic and then inform our decision-making that way.
Yes.
But it does explain why some patients completely escape the scourge of TD and others get it pretty quickly and pretty strongly. There's a condition, our listeners may be interested in this. There's a condition called the dyskinetic movements of the elderly, dyskinesias of the elderly. And this spontaneous dyskinesias of the elderly is the full name of it. And this looks just like TD. It was observed before the availability of antipsychotics. And as people age, some people get this and it looks just like TD. And they've never been on an antipsychotic. Well, it turns out people with schizophrenia are at high risk of spontaneous dyskinesias of the elderly. And there was a thought at one point that those who would have gotten spontaneous dyskinesias of the elderly get that movement disorder earlier upon exposure to antipsychotics. So that's interesting because if we can identify who gets these spontaneous dyskinesias of the elderly, there we have it. We have a
Yeah.
we have a smoking gun here in terms of who's going to get TD. Dan Casey did that work, actually. You remember Dan Casey?
Our friend. Oh, good friend. Loved Dan.
Yeah.
Went to University of Virginia, which is where I went to medical school. So, yeah, I do remember Dan very well.
Yeah.
He was also involved parenthetically in the publication of the guidelines of atypical antipsychotics and weight and metabolic disruption. He was one of the authors on that.
Yeah.
Of course, at the turn of the last century, if you read the writings of Bloiler and Kraepelin, they did describe movement disorders, and that was way before the era. So there is something different about the dopamine system. Okay, let's now shift gears and talk about what we really need to talk about today, which is the impact on the patient and the quality of life. So how can stigma affect a patient's willingness to seek treatment and stick to their medication?
Well, TD has been noted to lead to non-adherence and stopping medicine. It's also been noted to be associated with telling others to stop their medicine. That's the scary part. Imagine that.
Yeah.
You have a patient who's telling your other patients to stop taking their medicine because of the side effects. So that's a real problem. So that's definitely something that happens. We also have the stigma of someone with TD who is reluctant to be out in public or with others in general and becomes more socially isolated. So their level of functioning is certainly decreased. And that's a social aspect of functioning, right? And there's also, as we talked earlier, a psychological and psychiatric consequence of having TD, physical and vocational, educational, and recreational consequences. All this is wrapped up neatly in a rating scale that we can talk about. It's called the Impact TD scale. Now, I'm not suggesting we run out and use the scale every time we have a patient with TD, but it helps me remember what questions to ask. The scale itself will give pointers as to what kind of things we should consider when talking with our patients about the consequences of having TD. So in that way, it's useful. The AIMS itself has an item regarding distress and incapacitation. And I think we tend to gloss over these global assessments and these global ratings on the AIMS and just focus on items 1 through 7. But the remainder of the abnormal involuntary movement scale reminds us we need to ask, how distressed are you and what impact does it have on you? The Impact TD scale goes a bit further and can score the different domains of impairments and function socially, psychologically, psychiatrically, physically, and vocational, educational, and recreational, those 4 different buckets. It's free to use, it's free to download, and it's a useful concept to have in your back pocket.
Yeah. Could you do me a favor? So it was published by a friend of ours, Rick Jackson. And could you do me a favor and go through those 4 domains again that it is assessing?
Sure, it'd be my pleasure. I was a co-author on the paper which appeared in the Journal of Clinical Psychiatry in 2023. It's in the January-February issue. It's free to download and anyone can go on PubMed. And they would need to search, and I'll tell you the title of it. It's pretty easy to remember. Impact Tardive Dyskinesia, or Impact TD Scale. And first author, Richard Jackson, Jackson.
Right. So you were Dr. et al. In that publication.
Let's see. I'm 1, 2, 3. I'm the 4th author here.
Okay.
People were placed in alphabetical order after Dr. Jackson. So the scale, as published here, and this was based actually on prior work, which has also been published regarding impact, also by the same group of authors, is really tried to hone in on 4 buckets that are easy to remember. And I'll go over them one by one. Number 1 is social. So problems may include difficulty participating in events with family and others, such as holiday gatherings and going to church or going to synagogue. Self-consciousness and embarrassment about movements and being seen by others, so fear of stigma and rejection. And so people avoid interaction and decline invitations, stays at home. And there's a reduced quality of interpersonal communication as well. People are distracted from conversing, and there's problems interpreting body language. Now, this is an issue, right? If you're sticking out your tongue and you don't know why that person is sticking out their tongue, that can lead to some misunderstandings and consequences. Right. And so that is something that will be apparent with someone with TD. Now, some psychological and psychiatric impacts includes feelings of sadness and depression, anxiety, worry, concern, low self-esteem, hopelessness, less loss of sense of purpose, poor concentration, attention, and memory can also be associated with tardive dyskinesia. And they may have a worsening or recurrence of their symptoms, depressed mood, anxiety, psychosis, even aggression, and difficulty with appropriate treatment of their underlying disorder. They're not going to be as willing to take anything, and they may have reduced adherence, and they may stop their medicine. They may resort to very unhealthy coping strategies such as substances and alcohol. Some physical consequences, that's the third bucket, difficulty using utensils, writing, typing, dressing. The typing part actually applies today because we use keyboards much more than in the past.
Right.
Difficulty speaking, chewing, or swallowing, difficulty walking or maintaining balance, stumbling.
Wow.
Problems breathing. Some patients have diaphragmatic involvement and they're gasping for air and they grunt.
Okay.
They may have pain biting inside the mouth, as you mentioned, or they may clench their teeth, which can be painful after prolonged periods of time. And then difficulty sitting still. Those are all physical consequences of having TD. And then lastly, the last bucket, the fourth bucket, is vocational, educational, and recreational, all bundled into one. So it's problems gaining or maintaining employment. How can you have a front-facing job if you're sticking out your tongue at the customer?
That's right. Yeah.
Problems with recreational or vocational educational performance with poor concentration. So you might go to school, but you can't actually pay any attention. And so there may be challenges actually attending work, school, or other activities. Difficulty with interactions with people at school or at work, and difficulty performing tasks independently can occur in someone with TD if they're told to do something and TD gets in the way.
I see.
So those are the four buckets, and I mentioned the highlights of each category. Now, not everyone will have everything, but everyone will have something, and that something will get in the way of their happiness and well-being. And so it's not just enough to say, okay, you have this movement disorder, let's see if it goes away. We want also the impairments to go away. So if I can get that tongue to remain inside the oral cavity, it never sticks out. It's still moving inside the mouth, but it's not exiting the oral cavity. That's a huge win.
Right.
Huge.
Yes.
So I'm pretty pleased when I can dial down the tardive dyskinesia. I may not be able to eliminate it completely, but I can certainly do a whole lot more today than I was able to 10 years ago.
Yeah. So I can almost imagine, let's say you have a mood disorder and you're getting this medicine, and now suddenly these movements come, and I can imagine it being even more depressing or cause more anxiety, as you said. So that's compounding the problem. And of course, Les, you and I in the old days, and I mean before 2017, when I say the old days, we were taught to lower the dose or stop or switch the antipsychotic. And now you risk destabilizing the patient after you've worked so hard to get them on a regimen that works.
That's true. For MDD and adjunctive use of antipsychotics, we do have a way out, though, in that it's not absolutely necessary to give an adjunctive antipsychotic to treat someone with MDD. However, we have no way out right now with schizophrenia and in most people with bipolar disorder, where we must give a dopamine receptor blocking agent, at least for now.
Agree. I certainly agree. Well, that may be surprising to our audience to hear you run through those domains and some examples of how wide-ranging the consequences can be and how profound the effects on somebody's quality of life and function. And I was particularly struck when you talked about some of the physical aspects. I hadn't thought about all of these: speaking, swallowing, breathing, writing, maybe holding a cup or a glass. It's
absolutely
really incredible.
So one tell that you can use in your clinical assessment of patients with schizophrenia is if they come to your door or to your office and it's the middle of winter and it's really cold outside, and yet they're wearing a T-shirt and flip-flops. Something's up. So may mean they are neglectful, may mean they can't button buttons or tie shoelaces. And so a degree of improvement in their life and health would be able to tie shoelaces and button buttons. So truly, there could be some consequences with things we take for granted. Now, neurologists often dispute this with me. They say, no, that it cannot possibly affect someone's ability to hold a utensil and eat.
Oh,
But I'm very surprised to hear that from them because I've seen it with my own eyes
yes.
on inpatient units that I've worked on for many, many years.
I have too. Yeah, I've seen patients wearing sandals because they were getting sores in their feet when they wore shoes from moving around the toes too. So that's another aspect of this. You're right. All right. Maybe we could talk a little bit about how often do we assess and monitor? And I'm going to divide this into two, Les. The first is I think some clinicians may be intimidated by this idea that I have to somehow look for TD at every visit. Does that mean I have to do an Ames at every visit? That's going to take up some time, Les.
No, an Ames at every visit is not necessary, but looking at the patient is. So we have to look at our patient when we go and fetch them from the waiting area, when we walk with them to the consultation room, and as we interview them and conduct the interview, as well as conduct the psychotherapy if we're doing that, and as we're talking about medicines and so on. Too often, we're not paying attention, or we're kind of obsessed with getting it all into the EHR. So that's a problem, and we'll miss things. So it would be a good idea to let everyone in the office know that you need to be alerted if there's any abnormal movements that they notice in the patient as they're sitting around waiting to see you. So that's good information. And all this should be done every time. Look, we weigh everybody, or we should be, every time they come in. So we can do the same in terms of looking at them.
Yeah.
It doesn't cost any time. And the more you look, the more you find. And the easier it is to find. So our levels of observation become more keen. And we become much more skilled when we look for things and get used to looking for things.
Yeah.
So I can't help it. I know you do this too, Andy. When we go places to give presentations and we go, let's say, to a clinic or an office, we're sitting in the waiting area waiting for them to finish up with their patient. And there's usually someone in the waiting room, a patient.
Yes.
I look, I see TD.
Yes.
And, and when I'm giving a presentation on a treatment for TD, I mention this, so the patient waiting to be seen next has tardive dyskinesia. So I know you see it in this office.
Yes.
So I can't help myself. I look because I'm used to looking, and everybody can do that. It's a skill that can be developed with every clinician.
Yeah. Well, in fact, the APA guidelines and other guidelines recommend you should screen, not should, really, you must screen at every visit on anybody on a D2 blocking agent. Now, screen, as you said, doesn't mean a full Ames. Of course, you want to get a baseline Ames and then maybe do an Ames some regular interval, or certainly if you see movements. But Les, let me add something to what you said. I certainly agree you look for it. I say look for it and ask about it. So I ask at every visit, have you noticed any unusual or involuntary movements? Has anybody else noticed or commented? It takes a few seconds. And I think it's, like you said, I like the analogy of weight or blood pressure. It's something that we should be monitoring. Now, one other aspect we didn't talk about is the idea of informed consent. And it's very important, isn't it, that we advise patients about this risk and to let you know. I don't know.
Yeah, well, it's not generally done in someone who's acutely psychotic and being admitted to the hospital and receiving a medicine on an emergency basis. But once the emergency is done with, and someone is in pretty good shape, ready to go back home, a discussion needs to take place about the risks of whatever you have prescribed and documenting that in the medical record. If you do that, along with regular assessments, observing patients when they come in, maybe make a note. No abnormal movements detected in today's visit. If you don't see anything, and do that regularly. And if you do see something, then do an Ames. And then you're good. Yeah. You act on the Ames, of course. You do something to address the movements, but then you're good. And I say this in my role as an expert witness in legal cases. So I do a bit of this kind of work where I serve as an expert witness for both the defense and the plaintiff. And it's really indefensible when someone lets TD happen and does nothing about it. And it's completely defensible when they did all the right things. And I've seen it both ways.
Certainly. Wow, that's very sobering. Now, the second part I was asking here about screening and assessing the TD movements. And the second part of my question is, how often should we be screening and assessing the outcomes that we're talking about, the impact, I guess I would say?
So I think whenever we see TD, we need to figure out what kind of impacts it has, only to know what to expect with the successful treatment of the TD. So it also is a motivating factor in getting someone to acknowledge that, number one, they have TD and would benefit from a treatment, and it would be part of the motivational interviewing portion of our communications with patients.
How does that work? Tell me quickly, how does that work? How does that fit into the motivational interviewing? The impact.
So so what's getting in the way of working? So what's getting in the way of getting together with friends? And then all these movements, and it's really embarrassing. Well, before you were telling me that it didn't really bother you and it's no big deal. Well, okay. So if they can link a problem with something that you want to treat, and then they'll be more inclined to agree to the plan, or maybe even come up with the decision to treat. That would be terrific, because then they own that decision. They're more likely to be adherent. And as time goes on, remaining on a medicine to manage TD can be difficult for some patients because it's an extra medicine, and they may be feeling fine. So the thing about TD and the medicines for TD that makes it actually a lot easier for us is that when that medicine is stopped, the TD usually comes back, and usually comes back quickly, so that we don't stray too long off that medicine.
Yeah. You know what I say too, when you are bringing this up, it's like starting a conversation. Don't feel like you have to close the deal the first time. So patients, like you said, may be reluctant to take a second medicine. They may underestimate the impact. But if you bring it up and talk about it over time, you know what I mean? Instead of closing the deal the first time, you're starting a conversation. And that is part of the motivational interviewing, I guess, process as well, right?
Absolutely. It reminds me of what we do with long-acting injectables. We don't necessarily get to yes on the first time you introduce the idea. Yeah. But I got to tell you, even treating patients with MDD and wanting to switch a medicine out in order to enhance their outcomes is often difficult too, because they're better. They're not great, but they're better. Yeah. And they don't want to throw out the baby with the bathwater. They don't want to start fresh. So there's also concern with patients of not wanting to rock the boat. So I've had patients over the years with really bad drug-induced Parkinsonism. I mean, absolutely terrible. And we had, for the first time, second-generation antipsychotics, and I would tell them, and I remember one in particular sticks in my mind, I'd like to switch you from when he happened to be on flufenazine, to something new. It's called Lanzapine. It was brand new at the time, and he wanted nothing to do with it. He said, "No, I'm good. And he was trembling so much. It was sad.
It is sad, yes. Well, I can certainly remember a patient I had who was on chlorpromazine, very similar, and he had gained weight, and he was having some movement issues, and he wanted to stay on it because he was too scared of how sick he was before, and he didn't want to risk that. So, but even in that case, you start the conversation, and you can keep coming back to it. I like the LAI analogy. Now, I want to talk a little bit about impact on others and what role others can play, Les. And you did mention something very interesting. You talked about other members of your team, other people in your clinic or your office, helping you gather that data and observing. But what other roles can caregivers or family members play in, I guess, both recognizing, assessing, and even intervening with TD?
So the great opportunity is when a family member or a person living with that person comes with them to the session. And then you can ask them, how they're doing. And by the way, have they had any movements that seem surprising to you? And they'll tell you, and they'll be actually more likely to report it than the patient. Mm-hmm. And then there's trying to get them to describe it. And if it's intermittent and you don't see it in the office, but they see it at home, you can ask them to videotape it on their phone or video record it. We don't use tape, just record it. And then to bring it in next time. Yeah. And then that's very helpful. So that's asynchronous information that can be very helpful. Someone can catch someone having that movement at home, and then you can know what they're talking about. So they're very helpful in doing so. Yeah. And it's hard for the individual person to hold that camera and to show the movement.
Film.
Far easier for the family member to do it.
Yeah. And as we mentioned earlier, the patient may not be as aware of the movements, and so they may not notice them getting better, let's say. They may not notice the effects of treatment, and so there again, maybe the family member or the caregiver can give you a better assessment of, are you making progress with the movements in the therapy? And of course, they can also help, I suppose, with adherence to the treatment, giving the patient some feedback. What do you think about that?
I think so. Families can be very supportive in encouraging someone to continue their medicine and report back in a positive way about how much improved they are. I think also patients can report that socially they feel more comfortable. They're not going to say their movements went away. They're going to say they're more comfortable being with other people.
Yeah.
And that's directly as a consequence of the other person not staring at them. And they're not staring at them because they're moving less.
Right. Okay, well, let's now, I think we've really talked a lot about the impact, and as you well said, TD is much more than just a cosmetic disorder and movements. It can have wide-ranging impacts. Let's shift gears to management and treatment strategies. So how does effective TD management improve patient outcomes and psychiatric stability?
So the first thing I do is review the medicines that they're on.
Okay.
And if they're on a first-generation antipsychotic, I really encourage them to switch to a second-generation antipsychotic. And then if they're on a first-generation antipsychotic, invariably they're also on an anticholinergic.
Anticholinergic.
It's almost a guarantee. And then I'm able to dial that down over time. I can't do it overnight. Dialing down that anticholinergic will, in many instances, decrease the intensity and frequency of the dyskinetic movements. May not eliminate them, but I'll have a better idea of what's going on. And I've already finished fiddling with the antipsychotic dose because that can affect the movements. So once I know that their antipsychotic is stable in terms of dose and that I've reduced and eliminated their exposure to anticholinergic medication, and they still have TD, I can then treat the TD with a VMAT2 inhibitor, of which we have two to choose from. It's almost an embarrassment of riches having two to choose from. And
That's right.
They're not interchangeable, although they both share a common mechanism of action of vesicular monoamine transporter type 2 inhibition. They do it slightly differently. And that may be just enough for it to work in one patient and not the other, which I find I find very useful to me, because if one doesn't work, I try the other and I'm usually lucky, or the other way around. So having two is good. And having two also means we hear about TD twice as often, because they're both branded products and the manufacturers are very interested in promoting their products.
Yeah.
And if there's another guy promoting something similar, they're going to be more on top of their game. So we have the information being brought to us about TD more often. And I think that's a good thing. So the more we're aware about TD, the more likely we are to identify it, we'll recognize it, and treat it.
Well, it's unusual today to watch TV and not see a commercial from one of those two companies about one of those two medicines. It's raising awareness not only amongst us in the healthcare community, but amongst our patients and their families and caregivers. Now, you said something very interesting. Now, wait a minute. These are two different chemicals or molecules. They're a little different. So if I try one and the patient doesn't respond or tolerate it, I shouldn't give up on the mechanism. I should try the other one?
Absolutely. So they are somewhat different in how they work, just enough so. And, our patients' brains are different one from another.
Yeah.
And it could be a tolerability problem, and they're certainly different there in terms of how you dose it and how tolerable they can be.
Yeah.
And they also are different in terms of the occupancy of the transporter. So it could be that,
That's right.
Yeah, so that may make a difference with some patients. But look, they both work. When we give them to groups of people, they work real well. And I can't tell the difference one from the other in terms of overall efficacy.
Right. So the efficacy data, maybe you could speak to that, is very powerful and very similar between the two, right?
Yes, it is. And if you look at effect sizes, or one of my favorite topics, the effect size is almost as large as what we would expect with treatments for ADHD, and more robust than the treatments we routinely use for depression. And these work. So they work, and they work quickly. So there's a term called number needed to treat. How many patients do you need to treat with one intervention versus the other before expecting to encounter a response? Let's define response, just for fun, as a 50% reduction in the dyskinetic movements. Would you agree that a 50% reduction in dyskinetic movements is impressive?
I certainly would. And
say yes. Yes.
I would. And I want to come back to that, Les, but yes.
Yes. Okay. So let's say the NNT is there versus placebo is 5. That's actually very good.
That's tremendous.
Now, would you agree that stopping a medicine because of an adverse event is a problem?
It certainly is. That means it's intolerable.
Yeah. So, right. So how often does that happen? Well, we have number needed to harm to describe that. It's 100. It took 100 people to be randomized to either of the VMAT2 inhibitors versus placebo before expecting one additional patient to discontinue the clinical trial because of an adverse event. So we'll do one more bit of math here. 100, which is the number needed to harm, divided by 5, which is the number needed to treat, which gives us what?
20.
120. That's the likelihood to be helped or harmed. You're 20 times more likely to get great success, that is a 50% reduction in the dyskinetic movements, versus abject failure, having to stop the drug because of an adverse event.
Right.
20 times more likely. And you'll know the answer within a few weeks.
Wow. Yes, that's certainly impressive. I agree. Especially when you consider before 2017, we had virtually nothing to treat this. I wanted to come back to that 50% reduction because I think some people may think of this as an all or none. Either I totally cure the movements, totally fix them, or not at all. And you said a very interesting thing earlier about if I can get someone to stop protruding the tongue out of the oral cavity, even if it's still moving in their mouth. Well, I haven't cured the TD, but that can make a significant impact. Can you talk a little more about maybe harm reduction or how decreasing symptoms but not curing them might affect outcomes and impact?
Absolutely. You know, I do want to eliminate movements if I can, but there are many instances where I cannot. So yeah, a 50% reduction won't necessarily eliminate all movements, of course, they're by definition. But, you know, it's hard to eliminate all abnormal movements. And realistically speaking, if I can reduce the movements where it won't have as much impact on that individual person, I think we have made great strides in managing that movement disorder. So the classic example, though, is you no longer stick out your tongue. Well, that's a big deal. Or you're able to button buttons and tie your shoelaces. That's a big deal. If you can dial down the movements to where it is not as prominent as before, someone's ability to interact socially will improve, and their psychological and psychiatric condition would also improve. And of course, the physical impairments would be less. And I think overall it's a win. We'll try our best to reduce the movements to nothing, but we won't let that stop us from addressing these movements. So that's why I call 50% reduction as robust response. Elimination of movements is often realistic.
Yeah, and I think this brings up the importance of assessing the impact on the particular patient in the particular domains, because then we can see, okay, I've reduced the symptoms a certain amount, but have they fixed the impacts that are specific to that patient? So I think this is why it's so important to not just look at the degree of movement, but to assess that impact of the individual patient.
I agree, Andy. We're not just treating a number, we're treating a person.
Yeah.
And that person has goals, aspirations, desires, values, preferences. We need to take that into consideration when crafting a treatment plan and knowing when we've achieved what they want to achieve. Not what we want to achieve, but what they want to achieve. And if we think that way, we're ahead of the game.
I love how you just said that, Les, about the patient's preferences and values, and maybe taking the family or the caregiver into account as well, and getting them to help also assess the impact. So it takes a team of people, doesn't it? And speaking of that, why is a multidisciplinary approach so important in managing TD?
Well, sometimes TD will involve some consequences that you need some help with some others. More complex movements and confusion regarding differential diagnosis may make it important to engage the help of a movement disorder neurologist who has seen it all. And they're used to seeing complicated cases. They may be of help. A dentist is also very often involved in the care of someone with TD. And so you need to be able to communicate with all these folks who are providing care to that patient. As a psychiatrist, I feel like I'm at the nexus of all these connections patients have, and I coordinate the care as best I can. I do consult with an assertive community treatment team, ACT team, and they take charge in terms of the medical and psychiatric care overall of that individual and help us coordinate everything.
Yeah. No, that's great. And even, physical therapists, occupational therapists, I can imagine speech pathology, if somebody's having trouble speaking or swallowing, there are a lot of others. Well, Les, I like to end on an optimistic and a hopeful note. So I want to ask you a little bit about what kind of research is being done? What are some areas of research on TD, and what might we have to look forward to in the future?
Well, I think primarily our goal will be to eliminate TD from happening.
Yeah.
And that means having other treatments besides drugs that have affinity to the dopamine D2 receptor as an antagonist or partial agonist to treat the disorders that perplex us. So when we have new ways of treating schizophrenia and bipolar disorder and MDD that don't involve dopamine D2 receptor blockade, I think we will eliminate TD. The other interesting developments in the management of TD is to make the treatments more convenient. So we've seen this with one of the products that went from BID with food to once a day, and from multiple dose strengths with number of pills to make up that dose strength to a more simplistic one pill for each dose. That goes a long way. Ultimately, I'd like to see a long-acting injectable of a VMAT2 inhibitor to make it even more convenient.
You're talking about the VMAT2s here specifically. Yeah, make them more convenient.
Right. Yeah. And I'd
if a VMAT2, that's an interesting concept.
Yeah. And perhaps other VMAT2 inhibitors to that may be also subtly different, that may offer an avenue of treatment that our treatments don't touch right now.
What if we could understand the neurobiology even better, and that would lead to a different target or a different mechanism of a medication to treat this?
Well, yes, quite obviously so. VMAT2 inhibition is focused on one potential reason why people develop TD, and that is the upregulation of postsynaptic D2 receptors in the motor striatum, leading to an increase in number and function of these D2 receptors. So dialing down dopamine D2 signaling presynaptically does the trick there. But it could be that there are some patients with TD who have TD for some other pathophysiological reason, which we don't know why. And perhaps there's another approach to treat their TD.
Yeah. Well, you mentioned earlier about genetics. I know a lot of work is being done on the genetics, and this may lead to other targeted treatments that particularly would involve the type of genetic abnormality that you have affecting, one particular part of the neurotransmission cascade, if you will. So I think it is a hopeful time, both from the point of view we talked about of treating TD that's already there, but possibly even, as you said, maybe the best way to treat TD is to prevent TD, to avoid it entirely through some of these newer mechanisms such as the muscarinic agents that are showing great promise for the treatment of psychosis and schizophrenia. So Les, on that, I'm going to ask us to, we're going to have to wrap up. We're running short on time. Can I ask you for any final thoughts or any other words of advice for our audience?
Sure. I'd like to leave the audience with a sobering statistic. That is 85% of people with TD remain undiagnosed. And of those 15% that are diagnosed, only a little less than half are receiving a VMAT2 inhibitor. The rest are receiving treatments that don't work. So we can do better. And we can start to do better by recognizing TD and acknowledging that it has consequences that are of great relevance to the well-being of our patients. I think we can do it. And it's just a matter of knowing about what to ask and how to ask.
Yeah. Well, again, I want to end hopefully and say there are effective treatments available, these two VMAT2 inhibitors. So making the diagnosis is not the end of the world. And as you've said, documenting what you do and everything is important. So we don't want to sweep this under the rug or ignore it. And we need to look for it and ask about it, as we talked about. Well, Les, I think this was hopefully very helpful for our audience and will help in some ways decrease that rate of either underdiagnosis or misdiagnosis and lead to more patients getting recognized and treated. I want to thank you so much for your time today.
Well, thanks for the opportunity again to talk about my favorite topic. It's even more favorite now because we have something to do that works, something we can use to treat it.
That's true. Well, I want to thank you all for listening, and I want to say for more of our podcasts, both CME and otherwise, and for more of our educational offerings and to learn about our live meetings so you can see me and Les in person, please go to our website, which is NEIglobal.com. That's NEIglobal.com. Thanks for listening.
Thank you for your participation in this CME NEI podcast episode. To receive your certificate of CME credit, please refer to this podcast's description page for a link to print your certificate. This concludes the CME podcast presentation. For more information about NEI and our premier educational content, please visit NEIglobal.com.